3 a.m. A 52-year-old man walks into the ER, holding his back. "Worst pain of my life," he says, "like someone's tearing me apart from the inside." He looks uncomfortable but stable. BP 140/90, heart rate 95, respiratory rate 18, oxygen sat 98%. The triage nurse thinks kidney stone. The resident thinks muscle strain. Everyone's thinking something benign, but something doesn't add up. I check his blood pressure again. This time, both arms. Left arm, 140/90. Right arm, 110/70. 30-point difference. That's not normal. That's a red flag. I ask about the pain. "Where did it start?" "Chest," he says. Then moved to my back, like it was traveling down. Tearing, migrating. Blood pressure differential. This isn't muscle strain, this is aortic dissection. The aorta is tearing. Right now, layer by layer. The inner wall is separating from the outer wall. Blood is tracking between the layers, creating a false lumen. And that dissection is propagating, extending down the aorta with each heartbeat. If it extends into the coronary arteries, he gets an MI. If it extends to the carotids, he gets a stroke. If the outer wall ruptures, he bleeds into his chest and dies in minutes. We don't have time to waste. "Get me a CTA chest," I tell the team. Aortic dissection protocol, and call cardiothoracic surgery. Now. His EKG shows some non-specific changes, no ST elevations, but that doesn't rule out dissection. In fact, aortic dissection can mimic MI. The dissection can extend into the coronary ostia and cause ischemia. We get him to CT. The scanner takes 3 minutes, the images load, and there it is. Type A aortic dissection. Starting just above the aortic valve, extending through the ascending aorta, the arch, down into the descending aorta. Classic intimal flap visible. Blood flowing through both the true lumen and the false lumen. This is a surgical emergency. Type A dissections are fatal without surgery. 50% mortality in the first 48 hours if untreated. Cardiothoracic surgery is already on the way. We start medical management. Lower his blood pressure, reduce the shear stress on the aorta, IV esmolol to drop his heart rate below 60. Target BP 100/120 systolic. We need to stop the dissection from propagating. He's in the OR within 90 minutes. They replace his ascending aorta with a synthetic graft. Repair the aortic valve. The surgery takes 8 hours. He spends 5 days in the cardiac ICU, but he survives. Walks out of the hospital 2 weeks later. He tells me later, "I almost didn't come in. Thought it was just a pulled muscle." That decision to come in saved his life. So what are the teaching points? Point 1. Aortic dissection is the great mimicker. It can present as chest pain, back pain, abdominal pain. It can mimic MI, kidney stone, pulmonary embolism. The key is thinking of it in the differential. Point 2. Blood pressure differential between arms is a critical sign. More than 20 millimeters of mercury difference means dissection until proven otherwise. Always check both arms. Point 3. The pain is classic when you hear it. Tearing, ripping, worst pain of their life. Sudden onset, migrating pain, radiating to the back. These are high-risk descriptors. Point 4. Type A versus Type B matters. Type A involves the ascending aorta. It's a surgical emergency. Type B involves only the descending aorta. It's usually managed medically and less complicated. Know the difference. Point 5. Risk factors matter. Hypertension, Marfan syndrome, Ehlers-Danlos, bicuspid aortic valve, cocaine use, trauma, pregnancy. These increase your suspicion. Point 6. Don't give thrombolytics if you're thinking dissection. If you mistake this for an MI and give TPA, you can cause catastrophic bleeding. Always get imaging first if dissection is in your differential. The bottom line, aortic dissection kills fast, but it's survivable if caught early. High index of suspicion, blood pressure both arms, CTA for diagnosis, surgery for type A, think of it. Recognize it, don't miss it. Want 47 more critical care cases like this? Link in description.